All right. All right, Mike, if you could switch the view to our room. Which one is that? All right. You could switch the view to Dan. All right, we will, while we're waiting for the mic to fix, or the view to fix, change, we'll go ahead and start, since it's just, in the introduction piece. This is the Norwalk Hospital Association docket number 25-32808-CON. Good morning, everybody. Thank you all for being here, and thank you for for staying with us while we set up. I'd also like to thank the Connecticut State Community College Norwalk campus for hosting us today. The Norwalk Hospital Association, the applicants in this matter, seek a certificate of need for the establishment of cardiac services pursuant to Connecticut General Statutes, Section 19A-638, small a, 9. Specifically, the applicant seeks approval to expand its current cardiovascular services to include elective coronary intervention services without on-site cardiac surgery. Today is November 5th, 2025. My name is Alicia Novi. Amy Porter, the acting commissioner of the Office of Health Strategy, designated me to serve as hearing officer for this matter to rule on all motions and recommended findings of facts and conclusions of law upon completion of the hearing. This is a hybrid hearing. By that, I mean it is being held both in person and electronically via Zoom. Public Act number 21-2, as amended by Public Act 22-3, authorizes an agency to hold a public hearing by means of electronic equipment. In accordance with this legislation, any person who participates orally in an electronic meeting shall make a good faith effort to state his or their name and title at the outset of each occasion that such person participates orally during an uninterrupted dialogue or series of questions and answers. We ask that all members of the public mute the device that they are using to access the hearing and silence any additional devices that are around them. Also, I ask that anybody today put your cell phones on silent so that we can have an uninterrupted hearing. This hearing is being held. With the health strategy staff, gathering facts, application. We'll be asking the applicant. At this time, I'm going to ask each staff person assisting with questions here that to identify themselves, name, spelling of their last name, and OHS title. Start from the right.
Nicole Tomzik, CON Healthcare Analyst.
Hi, I'm Boyd Jackson. I'm the Director of Legislation and Regulation.
Annie Fiala, CON Team Lead. Also to our left, who will be helping us. Also present is Dan Chuka, who is assisting with hearing logistics and providing miscellaneous other support. Maida Capozzi, who will gather the names for public comment, is also joining us electronically along with Lazarus. The certificate of need process is a regulatory process, and as such, the highest level of respect will be accorded to the applicants, members of the public, and our staff. Our priority is the integrity and transparency of this process. Accordingly, decorum must be maintained by all present during these proceedings. This hearing is being transcribed and recorded, and the video will be made available on the OHS website and its YouTube account. All documents related to this hearing that have been or will be submitted to OHS are available for review through our Certificate of Need CON portal, which is accessible on the OHS CON webpage. In making my decision, I will consider and make written findings in accordance with Section 19A-639 of the Connecticut General Statutes. Lastly, as Zoom hopefully notified those of you joining by online, that you are being recorded. If you wish, I wish to point out that by appearing on camera in this virtual hearing, you are consenting to being filmed. If you wish to revoke your consent, please do so at this time by exiting the Zoom. If you wish to not be recorded and you are in person, please do so at this time. Please invoke your right at this time by exiting the room. All right. I'm going to start by going over the exhibits and items of which I am taking administrative notice. Then I will ask if there are any objections. The CON portal contains the pre-hearing table of record in this case. The exhibits that are identified in the table range from A to T. Ms. Fiala, Ms. Tomczyk, do we have any additional exhibits to enter into the record at this time?
No, not at this time.
All right. The applicant is hereby noticed that I am taking administrative notice of the following documents: the statewide healthcare facilities and services plan and its supplements, the facilities and services inventory, the OHS acute care hospital discharge database, the all payer claims database claims data, and the hospital reporting system, HRS, financial and administrative provisions, agreed settlement that may be relevant to this matter, but which have not yet been identified. Counsel for the applicant, Norwalk Hospital Association. Identify yourself for the record.
Yes, thank you. Benjamin Jensen from Robinson and Cole, joined by my colleague, Connor Duffy.
Thank you. Counsel for the intervener, Stanford Health, can you please identify yourself for the record?
Thank you, Hearing Officer Novi. David DeBassi, Stanford Health, and with me is my colleague Charles Norman, who is observing but not participating in the hearing.
Thank you. Are there any objections to the exhibits in the table of record? Administratively noticed dockets and documents. Attorney Jensen.
Thank you, Hearing Officer Novi. No specific objections to the exhibits in the table of record. We do reserve our right to object to use of the all claims payer database and other items to the extent that the disclosed purpose is something that we find issue with down the road.
Yes.
Thank you.
All right. All identified and marked exhibits are entered as full exhibits. Attorney Jensen, do you have any additional exhibits this time?
Not at this time. Thank you.
Attorney DeBasio, do you have any additional exhibit?
Not at this time. Thank you.
Great, thank you. Okay, we will proceed in the order established in the agenda for today's hearing. I would like to advise the applicant that we may ask questions related to your application that be addressed. We will do this for the purpose of ensuring that the public has knowledge and for the purpose of clarification. I want to reassure you that we have reviewed your application, the completeness responses, and pre-filed testimony, and I will do so again many times before issuing a decision. As this hearing is being held both in person, we ask that all participants, to the extent possible, should enable the use of video commenting during the proceedings. All participants in public shall mute their devices and should disable their cameras when we go off the record or take a break. Please be advised that although we will try and shut down the hearing recording during breaks, it may continue. If the recording is on, any audio or video that has not been disabled will be accessible to all participants. Public comment taken during the hearing will likely go in the OHS registration process. However, I may allow public officials to testify out of order. I or OHS staff will call each individual by name when it is their turn to speak. Registration for public comment can be done using the Zoom chat function, or if you are in the room, you can sign up at our desk in the front. Please list your name, make a public comment in the message if you'd like to sign up via the Zoom chat function. The applicant and the intervener witnesses must be available at public comment, as OHS may have follow-up questions based on public comment. If anybody written comments in lieu of speaking today, you may do so by emailing your comments to concomment@ct.gov. Again, that is spelled CONCOMMENT@ct.gov. Are there any other housekeeping matters or procedural issues? Ken?
On behalf of the applicant, no.
Okay, Attorney DeBassia?
On behalf of the intervener, no.
You both. Is there an opening statement from the
Applicant. We have a number of witnesses here today, including several clinicians, so I'll keep my remarks very brief. Norwalk Hospital is not here today asking for permission to open a new facility or even to perform new services. Since 2009, it has been authorized to perform emergency PCI procedures on its sickest patients. It has a fully equipped and staffed cardiac catheterization laboratory that is able to take on additional capacity and to safely perform these procedures for patients that are not presenting in emergencies. The witnesses today will in the city of Norwalk and its surrounding communities for access to advanced cardiac care in their community. And as many of us learned this morning, 10 miles in this part of the state can be an adventure. So the importance of having care at a local level is really important in this area. Many of the people in this room were before OHS a year ago today, seeking approval for the affiliation between New Vance Health and Northwell Health. Today is one step forward toward fulfilling commitments that were made in that application in the agreed settlement with OHS. OHS for its consideration of this application, and we welcome the opportunity to demonstrate that the criteria, statewide healthcare and facilities plan, and the CON statute clearly been established, that there no longer exists any logical reason to deny patients in Norwalk their choice about where they receive cardiac care. Thank you.
Sorry. Is there no the intervener?
Yes, thank you, hearing officer. Good morning, hearing officer Novi and members of the Office of Health Strategy. It's my pleasure to be here today representing Stanford Health as an intervener in this proceeding. The Stanford proffered witnesses today, Elizabeth Longmore and Scott Martin, will offer testimony to help OHS determine if the application before you would result in a duplication of services, a negative impact on the utilization of existing services, or that the proposed service population is an unmet need for these services, and that the application would not negatively impact the overall healthcare system. It is Stanford's contention that Norwalk cannot satisfy these criteria, and the application should be, as it has been previously, denied. It is ultimately up to you to determine if Norwalk's application for a CON does or does not satisfy the statutory requirements. Thank you.
Okay, thank you very much. Counsel for the applicant, do you have all your witnesses seated to your right or your left? Sorry.
We do, hearing officer Novi, and I just wanted to flag, there was a comment saying that people are not able to hear online.
Okay.
I'm happy to proceed, but
Can they hear us now?
Yes, we could hear you, but barely beforehand. It was very low.
Swearing in. Okay. If while we work on that, we can swear in witnesses. Are all of your witnesses to your left?
yes, they are.
I'm going to ask that you, for the purposes of the fact that we have one camera, if you could raise your hand as your name is said so that we know where you are located, and also help the court reporter in identifying that the person is present and where you are. Attorney Jensen?
Sure, and I'll introduce. First is Michelle Robertson, Chief Operating Officer of New Vance Health, and as of January 1st, the Market President of the New Vance region of Northwell Health.
Okay, if you just want to identify all of them, I'll swear them in as a group.
Okay. Next, and we're not quite seated in order, is Dr. Mark Warshawski, who is the Chief of the Chair of the Heart and Vascular Institute of New Vance Health. Next is Dr. Arshad Yekta, Director of the Cardiac Catheterization. Next, Dr. David Laumnitz, Chief of Cardiology at Norwalk Hospital. Next is Dr. Verinder Singh, Executive Director of Global and International Health at Northwell Health and Chief of Cardiology at Lenoxville Hospital. And finally, Peter Cordeau, President of Norwalk Hospital.
Okay, wonderful. I'm going to ask you all, please raise your right hand, and I'm going to swear you in as a group. I will ask you to answer individually, starting from Michelle Robertson, going down to the end with Dr. Yekta, sorry. All right, do you solemnly swear or solemnly and sincerely affirm, as the case may be, that the testimony you're about to give is the truth, the whole truth, and nothing but the truth, so help you God, or upon penalty of perjury?
I do.
I do. I do.
I do.
I do. I do.
Great. We will note for the record that everybody answered affirmatively to the swearing in. All right, I just want to remind you that when giving your testimony, please make sure to state your full name and to adopt any written testimony that you have submitted on the record prior to your hearing today. The applicants may now proceed. Are we ready to proceed with testimony? Okay. The applicants may now proceed with, yep. Sorry.
Thank you, Hearing Officer Novy. I just had a procedural question that I made Attorney Jensen
Yep.
aware of. Since we only have one microphone, how do you want to handle objections?
Raise your hand. We will pass it back to you.
Perfect.
I do
That's
apologize.
what I expected, but I wanted this to go orderly and not be disruptive
no.
and ask in the middle of a question.
Same goes for you. If you have an objection during his testimony, raise your hand. We will pass the mic back. All right. So, Attorney Jensen, you may now proceed with their testimony. I just ask that your witnesses define any acronyms for the benefit of the public and the clarity of the record.
Sure, and thank you, Hearing Officer Novy. And our first witness will be Michelle Robertson.
Good morning. Thank you, Hearing Officer Novy and the staff of the Office of Health Strategy for the opportunity to speak today. My name is Michelle Robertson, Robertson, and I adopt my pre-file testimony for the record. I'm the Chief Operating Officer for Nuvance Health, and as of January 1st, 2026, I will be the president of the Nuvance market part of Northwell Health. I trained and practiced as a registered clinical nurse prior to entering healthcare leadership and have extensive experience leading clinical operations for healthcare organizations across the country. I'm speaking today to provide an overview of why this application is so important for our patients and families in the Norwalk community and how it will help Norwalk Hospital to address a current gap in access to care and better coordinate and manage care for our most vulnerable patients. Since its founding in 1893, Norwalk Hospital has been committed to delivering needed care in our community and to all who need it. We are a nonprofit charitable community hospital, and the foundation of our mission is to meet the needs of our community when and where it is in their best interest and within our capabilities. Chief among these services is cardiovascular care, an area where standards of care have evolved in the last decade, allowing us to expand access to interventional procedures closer to home, as you will hear from my physician colleagues today. We currently provide PCI for the sickest patients who need it, yet are forced to turn away less acute patients who also need the very same procedure. This is based on an outdated regulatory standard, which you have recently updated and modernized to current standards of care. Today, patient choice for PCI is currently limited for residents of Norwalk and our surrounding towns, but it does not need to be. There are a few points I feel critical to make this morning. First, it is contrary to best practices in healthcare to rely on transfers and referrals outside the community to deliver care when you have local capability. In fact, trends in healthcare have continually emphasized the need for better coordination of care and management of patients' conditions to reduce costs and improve value. Healthcare organizations such as Northwell and Nuvance seek to be accountable for the cost and quality of care we deliver. Being forced to refer or transfer patients out for care they can receive at one of our community hospitals disrupts access and inhibits accountability for that patient's health. Further, Other facilities in Fairfield County, including Stamford Hospital, agree with our position regarding the importance of ensuring access to care within the same community and with the significant burden placed on patients who are forced to travel elsewhere to access care. And although there are other facilities in Fairfield County that offer elective PCI, our patients face significant barriers to accessing those facilities. As I'm sure you've experienced, Norwalk is located amidst the most heavily trafficked, congested corridor of I-95 on the eastern seaboard. Studies have repeatedly shown the heavy burden of traffic and congestion on commuting and transportation in Fairfield County and around Norwalk and Stamford specifically. Many of us experienced that on our way here this morning. These burdens fall heaviest, however, on the most vulnerable members of our community, which is a majority non-white community with a number of predominantly Spanish-speaking populations who rely on Norwalk Hospital for local access to care and may rely on public transportation or family support to access appointments and services. They are particularly burdened by having to travel to other locations in heavy traffic, and especially when they're experiencing a cardiac health issue, where access can be more limited, as Dr. Lomnitz will explain further. In summary, I'm confident that this application is consistent with and advances current clinical guidelines, OHS goals for the CON program, and the best interests of our patients in our Norwalk community. We will enhance equitable access to local care, provide patients with choice to receive elective PCI at a hospital they trust, closer to home, and with demonstrated lower prices than multiple other regional alternatives, including Stamford Hospital. Thank you for the opportunity to present my testimony today.
Next, and then feel free to pass it to the next person down.
Attorney DeBasio. Why don't we go through all of their testimony first, unless do you have specific cross-exam for one person or general questions?
No, that's, if I have, apologize. Is this on?
Yes.
Okay, thank you. Would it be acceptable to everybody if I have this specific cross-exam question for the witness that just testified, if I do that, and if I have general, wait till the end?
I just trying to
I
think about
don't-
efficiency.
I don't have one for this particular witness.
Okay.
But again, since we just finished with the first witness, I
Yeah,
wanted to
no.
make sure we were all operating under the same procedural understanding.
Understandable. I'm just trying to think of passing the mic back and forth as few times as possible. So do you foresee that you're going to have specific questions for more than like say 2 or 3 of the witnesses?
I don't expect that. I don't anticipate having a lot based on their pre-filed testimony. If they go
Okay.
beyond that, that may be a different story. But candidly, we're going to have that issue with passing the mic no matter when I ask my questions.
Give me a second.
Yep.
Go ahead, back on. Okay, so what we're going to do is I will hand my mic to you. We will allow for individual cross-exam after each witness. Just let us know, chime in. You're going to have my mic, so if I need to rule on anything, it's going to be a second. So we will make this work. All right, I will just come down from the stage really quick to give you my mic.
Thank you, Hearing Novi and staff of the Office of Health Strategy for the opportunity to testify in support of Norwalk Hospital's application today. My name is Dr. Mark Warshawski. WARSHOFSKY, and I adopt my pre-filed testimony for the record. I'm a practicing interventional cardiologist and system chair of the New Vance Health Heart and Vascular Institute. New Vance Health uses system-wide policies, protocols, and collaboration to drive high-quality cardiovascular care across our facilities. Quality and performance of New Vance Health that include both local and system-wide quality review and continuous improvement activities. Norwalk Hospital already cares for the most critically ill PCI patients through its STEMI program, that's ST Elevation MI, and can extend PCI care to elective patients safely, efficiently, and effectively. Case selection guidelines for PCI without cardiac surgical backup have been published by national cardiovascular societies and will be adopted by Norwalk Hospital. Norwalk Hospital has a safe and tested transfer to Danbury Hospital. Northwell Health, a leading provider of cardiac care in New York State, further strengthens our clinical and operational expertise. Northwell and New Vance physicians are already working together to optimize quality and performance across our systems. This application addresses a significant gap, a gap that restricts access to PCI for some of our most vulnerable patient communities. Patients from Norwalk and surrounding towns who choose Norwalk Hospital for their care are unable to get it at their chosen facility. This unfortunately side of their community. Transfers lead to diminished value of the care delivered, with poor patient experiences and higher costs. This is about more than just convenience. This is about delivering the right care where patients seek and need it. There are significant elective PCI in Norwalk. Norwalk Hospital projects significant volume for this program, as patients who have already chosen Norwalk Hospital for their care will have the option to stay to receive PCI if appropriate. Looking at Chime data shows an increase in PCI volume for the state of Connecticut. SG2 forecasts a 6% increase in PCI volume nationwide for the next 5 years. This is about patient choice and reducing barriers to care for our most vulnerable communities. The program will meet a need and will be operated in accordance with American College of Cardiology and American Heart Association guidelines. Approving this application will improve the cost-effective delivery of high-quality care consistent with the goals of the new statewide plan and CON program. The national guidelines and even payment decisions have evolved to recognize that elective PCI can be safely performed in facilities such as Norwalk Hospital. There is simply no justification for patients of Norwalk Hospital to be denied the freedom to receive their care at the facility they know and trust. Thank you.
Thank you, hearing officer.
May I just, per the hearing officer's order on the petition to intervene, there was not going to be a right to cross-examination. I understand from our discussion earlier, you are going to allow some limited cross-examination. I just do want to note for the record that the order said it would only be allowed under particular circumstances, and I'm unclear what basis has been provided by the interview to allow cross-examination.
Thank you. Yeah, so my order said that I may allow them to conduct if I determine I'm going to allow limited cross-examination to the criteria notice under Connecticut General Statutes 19A-639. So, what I'm using to make my decision, you'll have to stay to those 12 feet, 19, or 639A. We are going to stick to those 12 areas. If it goes outside of those areas, Attorney Jensen, feel free to object. But that's where I'm going to allow the cross-examination in.
Thank you.
If it's easier for the hearing officer for counsel. If it's easier for the hearing officer and for counsel, I'm only going to ask one or two questions I could approach so that I'm next to the hearing officer if you're going to object to my questions and she can rule on them from there. Rather than passing the mic back and forth.
If you're able to.
Yeah, yeah.
I have easier movement. Sorry.
Thank you. Thank you for Chofsky. Just following up on your pre-filed testimony and the testimony you've offered today, is it fair to say that the major reason Norwalk is filing for this application is choice?
Is patient choice and also better care for our patients.
Now, when you say better care for your patients, I didn't see anything in your paperwork. You're not alleging that the care offered by the other area hospitals that provide elective PCI service is somehow deficient, are you?
No, I'm not.
And you're not alleging anything in the paperwork that the care provided by the other area hospitals already authorized to do elective PCI service is unavailable to the patients in the service area, are you?
I think at times it is unavailable. Patients who are in the community may not have a car, may not have the wherewithal to get on a bus, to travel to these other places. And I know that if I had a relative, an elderly relative who was in the hospital, who needed a PCI in the middle of winter and needed to be bundled up in blankets to be transferred to another hospital unnecessarily, I think that is really, frankly, a crime.
Thank you. Maybe I asked a poorly worded question. You're not alleging by these elective PCI services, are you?
I'm not aware of the specific capacity of the other area hospitals.
Thank you. I have nothing further.
You can-
Of the Office of Health Strategy for my opportunity to speak in support of this application. Diekta, last name is spelled Y-E-K-T-A, and I adopt my pre-filed testimony for the record. I am the director of the Cardiac Catheterization Laboratory at Norwalk Hospital, where I practice as an interventional cardiologist. I kind of wanted to give you some background as to what we're currently doing at Norwalk Hospital, why we're able to do it, and what some of the limitations are. Currently, we've had a program since July 2009, and we've been providing high care to the sickest cardiac patients that come in. In addition to that, we have a very robust cardiac catheterization laboratory performing left and right heart catheterizations, diagnostics at this time, volumes year after year, in addition to support for primary PCI or for any PCI, in fact, with very complicated placements of mechanical support devices, including what we call intra-aortic balloon pumps, or IABPs, and Impella catheters, in addition to doing advanced techniques like pericardicenteses, which is basically putting needles into right adjacent to patients' hearts. So we're already doing very complex procedures, and the question is, well, the most important thing is that we have very experienced interventional cardiologists. All of our cardiology interventionalists have greater than 5 years of experience that currently provide our day-to-day care. We have ample support staff. We have on-call vascular surgeons. We have thoracic surgeons who are always readily available for us. We have an adept ICU, which is staffed by attendings, intensive, very experienced nurses who deal with the most sick patients who come in with STEMIs who have support devices in. We have cardiothoracic surgery available to us 24/7. Any time of day. I'm able to pick up my phone and call all of our surgeons without a problem. And we have very strict transfer protocols in place. We are able to get patients to where they need to, if they needed to, very easily. In addition, we have the equipment already in place to provide high quality care. We have advanced cath lab technology. We have upgraded equipment, and we have all the stents and all the balloons, catheters necessary for us to proceed with elective PCI program. I think the most important thing to understand is that this whole term of elective PCI, it's really kind of ambiguous. It's not as if these patients are coming in mostly walking in off the street, some symptoms, let me need an intervention. Really data has shown that a lot of elective PCI is really for acute coronary syndrome. So these are patients coming in, and if we don't intervene on these patients quickly, their prognosis is worse. There's no question about it, right? Patients, have, for example, high GRACE scores, which is an algorithm that we use to risk stratify patients. If they don't have revascularization within 24 hours, outcomes are worse. If patients come in who are high risk and STEMIs don't meet a STEMI criteria, so unable to bring to cath. If they're not revascularized within 2 hours, their prognosis is worse. So just to kind of give some examples and how ambiguous this term can be, we kind of understand STEMI as a term for an occluded artery. You have to open that artery up. We all know that not all occluded arteries present with patients. For example, I had a young female, she had chest pain, ongoing chest pain, but the STs weren't elevated, but they didn't meet ST elevation criteria. So I'm stuck. I had to transfer the patient. The transfer generally does not happen within a few hours. There's a lot of hurdles in the transfer process to any of our hospitals. I've had experience transferring to all 4 of our local PCI hospitals in Fairfield County. And by the time the patient got a catheterization, we found that the artery was occluded, her symptoms are resolved. And at that point, the benefit of PCI is actually questionable. And subsequently, the patient had no heart attack, and we treated her medically. But no question that her prognosis, unfortunately, is going to be not as good as she had urgent PCI. What about a patient that comes in that has a STEMI? I had a patient that came in last month who had a STEMI. We fixed the culprit artery, and there's 3 arteries in the heart. The patient had another artery which was also at a significant blockage, but because of the regulations in place, I couldn't simply put another catheter in, fix the other artery. So we had to have this patient be transferred during this hospitalization and proceed with a second procedure so they can have that other artery fixed. In addition, we have patients that are unstable, as I mentioned, who are very sick, who are coming in with hemodynamic compromise, their blood pressure is low, they're unstable. So we can put their support devices in, but then we can't do anything to fix them. And unfortunately, we know with hemodynamically unstable patients, oftentimes if these patients aren't intervened on quickly, their prognosis is worse. So I had a patient that came in, we put a balloon pump, transferred the patient, but unfortunately, by the time the patient got to the other laboratory or at the other hospital, they were out of their window of opportunity, so to speak. And unfortunately, the patient had a poor outcome. So I think really understanding that acute coronary syndrome is not this it doesn't all fit into boxes, right? Like, STEMIs are one aspect of it. There's a lot of crossover between STEMIs and acute coronary syndrome. Why is transferring not a good process for patients? I think Dr. Warshawski alluded to this, but there's multiple barriers. Obviously, the most important thing for us is delay. In order for us to transfer a patient for any PCI, you have to, number one, find an accepting hospital. That hospital has to have a bed available. we need an accepting physician, we need an accepting interventionalist, and then you need cath lab space. And that seldom happens in a short period of time. Unfortunately, most of now we tell patients that even if we see them early in the morning, by the time we are able to transfer you, you're not going to have the procedure the same day. They're oftentimes waiting for at least 24 hours, and hopefully it'll get done the next day, depending on the volume. The other thing is, from a clinician's perspective, is the continuity of care. I'm seeing a patient. I'm able to do an intervention on this patient. I know the patient. I understand what the benefits of PCI and how I'd want to go forward should this patient be intervened on. But I'm taken out of the equation. So the patient who has a trust with me, and we're unable to help them in those decisions at that point. Obviously, there's an increased cost, increased risk of infection, and the stress that it offers to both patients and their family to be transferred, in addition to a risk of having a second procedure. So, for example, if we do a diagnostic procedure at Norwalk, we obviously do the procedure to make a diagnosis, and then we have to take all the catheters out and then do a second procedure on the patient after we transferred them already. The other important aspect of it is if we transfer these patients to an outside hospital, which is not affiliated with Nuvance, it provides significant disruption to continuity of care. For example, once a patient is transferred, it's very difficult to get updated information, even through our electronic medical records at this time. We oftentimes don't know. We're trying to look at back channels, try to call, get information. Number two is oftentimes the patient may not come back to us. And we've kind of lost that continuity of care. We started with the patient, they go somewhere else, and they may follow up with somebody else. So that's kind of a loss. And I don't know why that happens, but there's many reasons why. But the other important aspect of it, there's a loss of in the sense of, I know that we finally had stent placed, but I don't know where the stent was placed. How did the results come out? Image quality, we seldom get images to review. And for example, I had a patient that came in yesterday who had a catheterization at another Fairfield County hospital. They wanted me to look at it. I had no way of looking at it. So it's unfortunate, but that's the nature of the medical field that we're living in right now. So in terms of elective PCI, how will we make it happen? There's already very rigid criteria. This is something that this is well established nationally. There's multiple cardiology workflows by, for example, the Society of Coronary Angiography Interventionalists, who already have criteria on how we could proceed with elective PCI without CT surgery backup. We already have equipment. We have 2 fully equipped cath labs. We have a full quorum of nurses and techs, and we're fully staffed 24/7 to handle these cases. We have advanced technologies, cath lab, we have intracoronary imaging, fractional flow reserve, or FFR, so we're able to really provide this comparable care to any other program. In addition, we would participate, as we do already, and we have done for the past 15 years, in the NCDR guidelines and the get with the guidelines as well. And we have very aggressive internal review. So we review all our cases internally, and we continue to do so. All of our data would be transparent, so it would be comparable to other places. So ultimately, why is elective PCI essential for us? I think there's many reasons. From a perspective, what you're asking them to do is currently provide care on the sickest patients and not have any other practice whatsoever, right? Medicine's is a continual learning process. Again, you're dealing with this quick door to balloon time that we need to offer, but the simple cases we're not able to do yet. The sickest patients you've allowed us to do, which I find to be very unfortunate for our staff. Elective PCI is done across state lines in New York and Massachusetts. And in fact, I've talked to many of my colleagues who started doing this in ambulatory surgical centers and outpatient labs. So really, for a hospital like us that's doing elective PCI on STEMI patients, it's very difficult to accept that we're not able to do elective PCI on patients. The local population in Norwalk is growing. PCI volume is also growing, mostly in acute coronary syndrome, so less the outpatient cases, but really the acute coronary syndrome is exactly the patients that I was talking about earlier. The most important thing is these patients stay in their home community with physicians they trust. I spent years dealing with these patients, and when it comes down to the trust we establish with these patients, they feel comfortable with us. They come to Norwalk because they feel comfortable, they trust the hospital. They have choices available, but they're coming to us for a reason. And ultimately, these patients are local, right? I don't think patients are driving past Stanford or coming from New York City or even to come to Norwalk. They really are local patients and they really want care from the cardiologist that they know and trust. I think ultimately we have everything ready. We have the patients who want to come. We have the staff who want to learn. We have the physician and equipment. We just need your approval now. Thank you.
Morning. I just have a, in your testimony, you referenced that Norwalk Hospital has well-established transfer protocols in place, including with its affiliated hospital, correct? And
Correct.
those are successful, correct?
They are successful.
So there are options in terms of transferring patients to other hospitals in the service area that by your own testimony are successful in terms of treating these patients.
Well, I guess I don't understand what the term successful means. I mean, successful in terms of be sure, but I don't think
Well,
success is,
you would consider that a success, correct?
again, definition of success is a little bit ambiguous to me.
That's fine.
I don't understand what that means. I mean, success, if definition of success is getting a patient from point A to point B, sure, but if it's clinical outcomes, I would argue against that because I think in delay in some patients for PCI may actually not provide a patient successful outcome because their morbidity and mortality may have increased.
Well, that leads me to my next series of questions. Danbury Hospital is affiliated with Norwalk Hospital, correct?
Correct.
And the ambulance service used to transport the patients between the two is a captured service. Do you understand what I mean by that?
I would need a further definition. of
It's
that.
owned by the hospital.
Okay.
Do you agree with that?
I'm sorry, I'm probably not the right person to be asking that question to.
But let me ask you it a different way. You didn't rely on and you didn't provide any data with regard to patient transfers between the hospitals and successful and unsuccessful outcomes, did you?
Objection, just to the extent that the witness that already said he doesn't understand what successful means.
That the patients were transferred from one hospital to another and were able to receive an elective PCI procedure at the other hospital. The question is simply, you didn't rely on or provide any data. Is that correct?
Oh, I'm sorry, microphone. Okay, I apologize. I understand your objection. I'm going to limit the question to whether or not the person was able to get to the hospital and get the procedure. I feel like he would know if that happened.
So are we talking, I mean, if this is a specific patient or just, I mean, there are examples of both where patients are able to be transferred and have an intervention, but there have been examples where patients are able to be transferred and are unable to have the intervention.
Well, thank you, doctor. That leads me to my next point. You're testifying about this anecdotally, meaning about individual stories. You're not relying on any, you didn't review any data regarding these transfers before you came here and testified, correct?
These examples were anecdotal, correct?
Thank you. I have nothing further.
Thank you, Hearing Health Strategy, for the opportunity to testify today in support of the name is Dr. David Lomnitz, L-O, M as in Mary, N as in Nancy, I-T-Z, and I adopt my pre-filed testimony for the record. I'm a practicing cardiologist in Norwalk, and I serve as Chief of Cardiology at Norwalk Hospital. I want to give the group here a window. 5 years. Cardio specializes in imaging. I'm not an interventionalist, but I'm on the front lines of seeing patients, but in the office, in the hospital, and referring them for the find opportunity. And I think that it's important for everybody to understand from a patient's perspective what it's really like. So let's take us through some patients. So one patient comes into the hospital, they're having chest pain, they're diagnosed with a heart attack. Because of their EKG, they do not qualify emergency intervention, the PCI, percutaneous coronary intervention, where you get the balloon and the stent procedure. Suffered a heart attack, we still have to tell them they suffered a heart attack because that's what happened. And now we have to recommend their next step. They're obviously very frightened. They're scared. They don't know what this means to their mortality, their longevity, their quality of life, their family, their children, right? Uh, and after going through the whole meaning of this and what we can provide them, and the good news is that we can tell them that we have to send them to another hospital. But you can understand that the level of that can't be quantified, can't be quantified in a pie chart or any other Excel spreadsheet, is very palpable. And I feel it and I see it every day for the past 25 years. So naturally, so then you have questions. Where am I going? When am I going? Where should my family members go to meet me? I don't know. I don't know if they should meet you at the hospital, in the emergency room, in the cath lab. Who will be performing the procedure? I don't know. I spoke to a doctor. That doctor may do it. He may not do it, or she may not do it. We just don't know. What time? Right? And I want you to eat, and since we don't know, we're not going to feed you. What if it doesn't happen today? We don't know. We'll find out. All these questions come up for these folks. And so you can imagine, is this really the kind of care that we want to be delivering if we have good options and put that type of when it's really, I think, in my opinion, and I think in the opinion of, science and data, avoidable, right? So then we have the issue of patients who I see in the office and they are having chest pain, they have an abnormal stress test, and I recommend the procedure. I think someone doesn't want me to talk anymore. I think it's Stanford Landscaper. So in any case, so for a patient who has chest pain and abnormal stress test, this is a procedure that has been shown unequivocally to reduce the level of angina of chest pain. They can be treated with medicine, but unequivocally, angioplasty has been shown to be more effective at reducing symptoms. So for these patients, they have to now decide whether they're willing to go to another hospital and handle the travel and the logistics. My hope whether to have the procedure or not based on logistics and travel concerns, but whether what's right for them and their willingness to do the procedure or not. And I think adding these logistical concerns, I've seen in my own personal experience, where it does enter their decision making and it does ultimately will push them one way or the other on some occasions. And that's a shame, really. So then the next question is, who does this impact the most, right? And we know that from lots of literature that underserved communities, elderly, economically disadvantaged people are less likely to get these procedures than other groups. And the availability tends to be, well, we know that the number of PCIs that are being performed is actually growing substantially in elderly, in underserved, in minority disadvantaged groups as access has increased. And I think that's a wonderful thing that they're catching up with other. So as we talk about this, um, I also need to mention, what are some of the downsides of folks going to other hospitals besides, some of these questions that Dave have that are very personal and affects them and their experience. What we see is that, here we're talking about one procedure, one cardiac procedure, but people are much more complicated than that. They have other diseases. They have other specialists that see them, a lung specialist, a kidney specialist, a rheumatologist. When they go to another hospital, not only are they not seeing a cardiologist that they've known, but they're not going to be surrounded by all their specialists that have taken care of complex medical issues. And the lack of that, and to not recognize the importance of not having people who've known treat them best. And I think that's also an unfortunate outcome of moving people to other hospitals. I think actually the good electronic health record promises a lot, in terms of transfer information, but the reality, we really don't have a good flow of information. We can't see images. Oftentimes things have to be repeated because of that lack of transfer. We have a wonderful, in theory, in my practice, I look, the information simply doesn't exist. And it just, results in this day and age of artificial intelligence, the cornerstone of medical records is still the fax machine, and that's just the reality that we live in. And then another to all this is the patient will then come back and be grateful for hopefully a successful outcome. But then they wonder, what? Please come to Norwalk Hospital, because if they're having chest pain, we don't know if it's a full thickness ST elevation MI, right? One where the artery is completely occluded, where time is of the essence. And if they don't go to the nearest hospital, they may not make image. And I think that it's natural for a patient to ask those questions, and they may take my advice, and they may not, and they may suffer from it. And I think that, an important consideration, because it's a very, very logical question that patients ask all the time. I also want to personalize this a little bit. Family, including myself, emigrated from South America. I am been participating and caring for a large Hispanic group of patients and participating in the Norwalk Community Health Center and the subspecialty clinic. And I think speaking this day and age where immigration policy the reluctance, more and more of their employees that they're not familiar with. And I think the fact that, again, difficult. I just finished by saying that I think that whether we realize it, patient experience for Norwalk residents is less than, it is not equal to, definitely less than those at their local hospital. And I do feel that they're like secondary citizens, and I think that's a real shame, especially when they ask me why can't we do it, knowing that we've had an amazing track record in sick patients, and to implore you that historically there really made a lot of sense, and first of all, to have that surgical background really high volume sense. But just like your computer is not the same computer as the class C, PCI is not everything changed for the better and to the advantage of patients. And I really hope that for our residents that we can advance this and give them the same opportunity that our other communities have, and also around our country where they've adopted this much more aggressively than Connecticut, allowing elective PCI in hospitals without surgical backup. Thank you.
I'll try. 1, 2, 3, 4, 5, 6, 7.
One, two, three, four.
So everyone says that's better, so just make sure to lift up the back so that it's really pointing to your mouth. You hold it like this, speak across the microphone. If things come up again, we'll pause, try to speak. Thank you.
Just a reminder as well for everybody in the room, please put your cell phones on silent. We are having hearing issues, so I would hate for it to pick up your cell phone over the voice of the speaker. All right.
All right.
Yes, I will accept.
Good morning, doctor. I just have 2 or 3 questions.
It was the cumulative individual experience of my patients. Yes, it was.
Collectively, you were telling a story. Well, the initial question,
The objection is that that's an argumentative question.
that's fine, I'll move on. You talked about the challenges patients face with regard to travel and logistics in terms of elective PCI outside of the Norwalk Hospital Service Area. Do you recall that?
Yes,
And we're talking about elective PCI, correct?
yes,
And for the benefit of the public, I just want you to make sure I understand, you know this, but elective PCI is when the patients make an appointment and they come in and they have the procedure, correct?
incorrect.
Well, let's talk about outpatient PCI.
Outpatient PCI is one as defined by the state regulatory issues. elective PCI incorporates those for both inpatients who have suffered a heart attack, is still considered elective PCI. And
Outpatient, like, have them if they make an appointment, come in, have the procedure, and they're discharged, correct?
correct.
So whether or not they went to Norwalk Hospital or any other area hospital, they'd still be faced with travel and logistics, which you're talking about, correct?
Well, it'd be comparing traveling to Los Angeles. Both are travel, but they're a little bit different experience.
Well, we're not talking about making appointments in Los Angeles for this procedure. Well, correct? We're talking about area hospitals that are within, let's say, 25 miles.
For those, without cars and relying on public transportation and family members, I think that hurdle, they would have to speak to that. But to me, when I explain to them that it won't be done at Norwalk Hospital, you can see the gasp and the additional logistical burden that places on them. Not everybody has that sort of access.
I'd like to strike that I'm responsive to my question. I asked specifically about the area, not the challenges.
Happy to respond. The answer was giving context to what the question was about whether driving 25 miles was a significant burden or not. He was answering that. Okay, can you restate your question?
My question was based on, he compared traveling to Norwalk to Los Angeles. And then I asked, we're specifically talking about area hospitals within about 25 miles, correct? And then you then answer about challenges. So that's really a yes or no question.
Let's rephrase the question to traveling to a local hospital.
Come close to your mouth and allow for a moment for commitment. I think part of the problem is we're having rapid sessions between microphones and really can't go back and forth somehow.
Fair enough. So doctor, we're not talking about patients making a choice between Norwalk Hospital and LA on the other side of the country. We're talking about patients making a choice and making an appointment at a local hospital. Is that fair to say?
I think the question is that they have to travel one way or the other. And my response was that, yes, they have to travel, but all travel is different. And so just the fact that they have to travel doesn't make it the same. So
Thank you, doctor. You talked about the record. What record those are presently used for electronic medical records?
Cerner,
Is Norwalk now or planning in the immediate future to move to the Epic system? Do you know what the Epic system is?
yes, I am aware of it.
And is Norwalk planning on moving to the Epic system now or in the near future?
I'm not involved in that decision. I don't know.
Thank you. I have nothing further.
All right, let's take a break. And we will start the recording.
Are you ready?
Yes.
Attorney Damasio?
Yes.
Aye.
Hi, I'm Verinder Singh, Dr. Verinder Singh. Last name is Singh. I adopt my pre-filed testimony. I am the Senior Vice President for Cardiology for the Western Region for Northwell Health. I also hold a Senior Vice Presidency title for International and Global Health, and I'm Chairman of Cardiology at Lenoxville. But my testimony today is as a doctor and a clinician and a practicing clinician. I think it's very important for people to understand what actually happens on the ground. And I will try and explain this to you from our experience at Northern Westchester Hospital. Norwalk and Northern Westchester are very similar in my mind as community hospitals that have existing cardiac programs that we want to expand. Yesterday I did procedures at Northern Westchester and I saw patients in my outpatient setting. So I'm an active clinician at a hospital that I helped expand the program. So I hope you get from me what actually the benefits are. I'll give you the history of Northern Westchester. Before 2020, we did not have a cardiac program, September of 2020. We were getting patients transferred from Northern Westchester down to Lenoxville Hospital, a significant number of patients. And we made a strategic decision to stop that. Why would we do that? We did that because we understand that local programs, full, rich, established local programs will give the best clinical outcomes. And how do they give the best clinical outcomes? Really for three reasons. One is quality, two is continuity of care, and three is access. And what was our strategy? And it's always been our strategy in every place we expand a cardiac program. We don't do this as a satellite. We do this as an extension model. So Northern Westchester was not a satellite cardiac program. It was an extension of the Lenox Hill program. The Lenox Hill program is an extension of the larger Northwell program. What that allows for is a true integration. So from a quality standpoint, we have all of our cardiac cath labs at our cardiac programs show up for what we call a task force. And there's only one criteria on that task force. You better check your ego at the door because we're all going to learn from each other. And they focus on QA, QI. They focus on quality, technologies, protocols, staffing. And I think staffing is really important. When we open up an extension or expand an extension, a program, we staff with our own people. Northern Westchester, not just our doctors, but our nurses, our technicians, our ACPs. Some of our best doctors, nurses, and PAs were the ones that wanted to go up to Northern Westchester. It was a benefit to them because of their lives, or they wanted to try something new. It was a value for them, and it was a value for Northern Westchester because we gave them very quality people. That's immediate staff. There's also future staff. We have a med school, we have a nursing school, we have an ACP, PA school. In fact, we're starting a high school that is really focusing kids on healthcare. So future pipeline for staffing, and that's what we are going to be able to offer, not just to Northern Westchester, but also to any hospital that we extend and expand their program. I'll switch to continuity of care. And this, I think, is where being a practicing clinician is so important. The accountable, effective communication that I can have in my own ecosystem is really what determines patient outcome. I will give you an example that happens 1,000 times a week. For all of us, you do a procedure, the patient calls you 2 days later, something is going on, okay? You talk to them, you should go to the emergency room, right? I advise the patient, go to the emergency room. What do I do in that meantime? I call the emergency room. I know the emergency room doctor. I say, look, I'm the one that did the procedure. The patient called me. This is my differential diagnosis. When he arrives, this is what I would recommend that you do. It becomes a much more directed evaluation as opposed to somebody showing up and just saying, yeah, I had a procedure a couple of days ago, right? That's just common sense and it's logic. and it happens all the time. The second thing that a continuity of care model does is it allows for us to build a true program locally. Local care supersedes all other care. What does that mean? Outcome is determined pre-procedure, procedure, post-procedure, but then what happens to the patient when they leave the hospital, right, into the community? So what we do is we build what I call halo program, like prevention. So like the patient I did yesterday at Northern Westchester, I said to her, I just stamped out a fire, but the entire forest is on fire. You have to put out that forest fire with diet, exercise, medication. I'm going to help you because we have a prevention program that we built in our expansion of Northern Westchester. What does that do? I don't want to see that patient come back, right? I want to see her live a healthy, long life and just get healthy. We would not have been able to do that unless we had a local program based in continuity care. Finally, access. And I agree with you. The lower members of our community, we have to take care of our entire community, the top 5% and the bottom 5%. But where access really helps is in the high-risk patient populations, the patients that the social determinants of health. They're poor, they don't speak the language, they're immigrants, they're in the service class. Those are the patients where access really, really helps. And I will make the argument that I have lived this because we have affiliates in Wyckoff Heights, Brooklyn, a very high-risk population, and Jamaica Heights, Queens. Both of those affiliates, they're not part of Northwell, they were affiliate existing cardiac programs. They came to us and they said, we would like you to help expand our existing programs. And one of the first things we did was give them expanded access and procedures, but that's also evolved to, they don't have the resources to have a prevention program. They don't have the resources to have a heart failure program, but we do. So we do hybrid programs with them. And those communities, especially the high-risk communities where there are hospitals that don't have the resources, we've actually done that. Those patients, we talked about outpatient and like inpatient. The outpatient is one component of elective. Every week, I see what is termed elective patients who are high-risk elective patients. They're in the hospital. They've had a non-STEM, right? What we were talking about before, like the GRACE score. Technically, in the spectrum of elective and emergent, even in elective, there are very high-risk subpopulation. The access that we have given to some of these communities that have high-risk patient population, it's pretty impressive. Every week, I see patients being transferred from Jamaica or Wyckoff that would have been listed as elective, but they really were actually the high-risk elective. So based upon my experience at Northern Westchester and Northwell's experience at Northern Westchester, I strongly believe that all stratas of the Norwalk community will benefit from an expansion of the existing Norwalk cardiac program. Thank you.
No questions.
My turn. All right. Thank you, Hearing Officer Novi and OHS staff. I am Peter Cordeau, C-O-R-D-E-A-U, and I adopt my pre-file testimony. I am president of Norwalk Hospital, a registered nurse, former chief nursing officer and president at Sharon Hospital, and also a former cardiac service line director at St. Mary's Hospital. Thank you for the opportunity to conclude Norwalk Hospital's CON testimony. We have heard a lot today regarding clinical standards, evolving guidelines, changes in the statewide plan, improvements in techniques and treatments. I can't overemphasize that this is not a de novo program. This is a high-functioning cath lab with exceptional interventional cardiologists, nurses and techs backed by Northwell, and Nuvance's extensive quality and performance improvement process. This proposal will certainly expand access and address the gap in care, especially in Norwalk's most vulnerable communities. It is important to note OHS has repeatedly indicated to Norwalk Hospital and Newvance the importance of keeping services local, such as our inpatient behavioral health certificate of need. This is the other side of the same coin. We're committed to fulfilling that expectation, a commitment made by Northwell and Newvance in the agreed settlement to enhance and expand local access. But what about the patient perspective? And what about if that patient's me? How my personal experience is emblematic of the significant need for this application approval. I receive all my medical care through Norwalk and Newvance. I'm the typical patient Dr. Lomnitz spoke of. And after a positive stress test and a positive nuclear stress test, a cardiac catheterization was recommended. Do I have it at Norwalk, the hospital I'm president at? What if I need an angioplasty? There's high likelihood I need an angioplasty. Do I expose myself to twice the contrast dye, twice the radiation? Or do I go to a facility that can perform elective angioplasty? I did choose to go to the facility that had elective angioplasty, but the kicker is it was the exact same physician. It couldn't perform an angioplasty in Norwalk that could in another facility, the exact same physician. There is a need to approve this application when a hospital president, nurse, and cardiac service line director has difficulty navigating. Imagine the general public and the vulnerable populations. They don't have the same advantages that I do. Patients want to receive their care at a local hospital, not disrupt or fracture care as mentioned. We seek to enhance access and choice to high quality, cost-effective care. As OHS found relevant in its approval of a new imaging joint venture that coincidentally includes Stanford Hospital, and I quote, "We now seek to increase local, equitable access to needed services in a convenient location, particularly for the vulnerable members of our community." That facility I could see out of the window of my office. That same vulnerable community deserves local, equitable access to elective angioplasty at Norwalk Hospital. The community has made its voice heard in strong support of this application, evidenced by hundreds who submitted letters of support or signed a petition supporting elective angioplasty. I urge OHS to listen to the voices in our community and approve this application. Thank you very much.
No questions.
Okay. At this point, I'm going to go ahead and ask Attorney Cavazio, do you have any questions for the overall general population? Or for the rest of the applicants or?
No, thank you, Madam Hearing Officer. I asked my questions as we went along with each witness. I appreciate the courtesy.
No problem. Then we'll go to Attorney Jensen. Do you have any redirect?
I do. Thank you, Hearing Officer Novi.
Can you share the mic or would you like me to send it?
That would probably be easiest because I only have a couple of questions for a few different people. And then we can start with Dr. Yen. Dr. Yetta, during the questions from Attorney Cavazio, there were several questions about whether you and Norwalk Hospital generally relied on hard data about patient outcomes following transfers. Do you recall that?
Yes.
And when a patient is transferred outside of the Newvance system, do you always get hard data and information about those patient outcomes?
We don't, no.
And why is that?
I think, as alluded to earlier, there is a paucity of information exchange in terms of both EMR accessibility, but also physician communication from outside hospitals.
So when a patient is referred out from Norwalk Hospital and receives care, whether it's at Stanford Hospital or St. Vincent's, is it true that you don't always get the full information back about the care that was provided, the results and the outcomes, such that we could have tracked it and provided it in the application?
I think it's very difficult to get that information. I think we may get
you may be able to get reports oftentimes after patient care has already been delivered, but obviously, as alluded to earlier, images and things like that are nearly impossible to obtain.
Thank you. If you wouldn't mind handing the mic to Dr. Singh, please. Dr. Singh, during your testimony, you discussed extension programs throughout Northwell, including at Northern Westchester Hospital. Is that right?
That's correct.
Can you just confirm, will those same programs be made available to Norwalk Hospital?
Absolutely. It would be an extension of our extension model.
Thank you. Next, Peter Cordeaux, please. Mr. Cordeaux, there were some questions earlier about the ambulance service at Nuvance. Do you recall that?
I do.
Okay. Can you answer, does Nuvance's EMS program convey patients between hospitals?
No, we are, we are the 911 service for Norwalk and 4 or 5 surrounding communities where we provide the paramedic flight cars. We are not a transfer service.
Okay, so when transfers are performed in the context that we're discussing, patients who are treating at Norwalk Hospital and need to be sent somewhere else for an elective PCI procedure, are those transfers completed using Nuvance's EMS?
No, they are not. They're with the private EMS companies that are licensed to transfer.
And there's a cost associated with those transfers?
Yes,
Thank you.
sometimes borne by us, many times borne by us.
Thank you. And then Michelle Robertson, please. Ms. Robertson, there were a number of questions during the cross-examination about the availability of other facilities in the region that have capacity to take on elective PCI patients. Do you recall that?
I do.
And is there a cost impact to your knowledge in connection with the transfer of patients to these facilities?
Yes, there is, and I believe we have supplied some of that information related to costs, but you have duplication of test services that are borne by both facilities, and those are oftentimes passed on to the patient.
And even if the patient presents directly at one of those other facilities, based on the data that Norwalk has disclosed, is there a cost difference in the care that they receive at those facilities?
Yes, and we have submitted that information as we know it from state data.
Okay, what does that state data tell us about the comparative cost between Norwalk Hospital and these other facilities?
That Norwalk is at a lower cost.
And what is the impact on the various value-based care initiatives that the state promotes from requiring these transfers to higher cost facilities?
One of our obligations is to ensure that the total cost of care is lower, and from a value-based perspective, it actually looks at not only the costs of the patient, but the costs that are incurred by the facilities. And from a value-based perspective, you're supposed to provide the highest level of quality care at the lowest affordable cost.
Thank you. No further questions.
Sure.
Normally would take a 5-minute break at this point. We brought sidecar. Would you like to take 5 minutes before the intervener? Would you like to plow through? We're not going to be able to get to our questions before the lunch break. So we're going to just do the intervener presentation of testimony, cross and redirect. Do we want to take a 5-minute break at this point?
I'd like to take a 5-minute break.
Let's take 5 minutes, a real 5 minutes, last 5 minutes, 7 minutes. So take us off to that too.
Okay, so we're gonna take a 5-minute break. It is now 11:17, and we will come back at 11:22. Thank you, everybody. Need a microphone too. I'm gonna come down here. I'm gonna come down here and do my part, so you can come back to the microphone. Counsel for Stanford, Please identify all the individuals by name, and title who are going to testify today. I will swear you in as a group after you've been identified. Please just raise your hand so you're on camera when you're called.
Thank you, Hearing Officer Novi. Immediately to my right is Elizabeth Longmore, MSRN, who is the Executive Vice President and Chief Operating Officer of Stanford Health. Next to her is Dr. Scott Martin, who is the Director of Interventional Cardiology at Stanford Hospital and Stanford Health Medical Group. They will be subscribing to their pre-filed testimony and offering testimony in support of Stanford Health's intervention petition.
Thank you, Attorney DeBasio. If you could please both raise your right hands. Do you solemnly swear and solemnly and sincerely affirm this case may be testimony you're about to provide to be the truth, the whole truth, and nothing but the truth, so help you God, or upon penalty of perjury? If you can just say your name and say yes, and then pass the microphone to the person.
Elizabeth Longmore, Longmore. Yes.
Scott Martin, Martin, yes.
Thank you. Okay, I just want to remind you that when giving your testimony, please make sure to state your full name, adopt any written testimony you have submitted on the record prior to testifying today. The interviewer may now proceed with testimony, and I just want to remind you that I ask all witnesses to define acronyms for the benefit of the public and the clarity of the record.
Thank you, Hearing Officer Novi. Stanford Health is starting with Elizabeth Longmore.
Thank you very much, Hearing Officer Novi and members of the OHS Commission. My name is Elizabeth Longmore, and I am not my pre-filed testimony. I'm the Executive Vice President and Chief Operating Officer at Stanford Health. I am also a registered nurse with an extensive background in critical care and emergency care. According to the American College of Cardiology, patients who receive elective PCI during the primary hospitalization do so for convenience and ease of scheduling, not because of the patient's clinical situation demands it or demands the procedure prior to their discharge. There are currently 4 existing full-service cardiovascular programs that perform elective PCI in Fairfield County. Every town in Norwalk Hospital's primary service area is within a 30-minute drive of one of these 4 cardiovascular centers. The application contains no evidence of wait lists, delay days from the date of the scheduling request to the actual elective PCI, or evidence of cardiac diversion at the 4 existing elective PCI centers that are proximate to Norwalk Hospital's service area. There are no statistics on the numbers of patients transferred by ambulance for urgent PCI or the receiving hospitals versus the number of patients who are discharged to home with a scheduled outpatient PCI appointment. Stanford's cath lab is able to accept PCI referrals on a same-day basis as clinically indicated or requested by the patient's cardiologist. Our cath lab is available to patients 24 hours a day, 7 days a week, 365 days a year. The nurses and the technologists who staff our cath lab are highly trained individuals, highly educated, and they are in dramatic short supply. According to a report that was published by MedAxiom, an American College of Cardiology company, in its April 2022 survey, it revealed that 96% of labs reported challenges with staffing their cath lab and cath lab programs, with 85% also reporting that staffing has worsened since the COVID-19 pandemic. Further, 85% of labs reported utilizing travelers or some type of interim staff in their labs. Recurrent difficulties are compounded by the fact that cath lab on-call duty requires that cath lab nurses and technologists be within 30 minutes of the hospital, which dramatically limits the eligibility of the employee pool to a defined geography in order to meet these service requirements. The existing 4 elective PCI programs already compete for the same limited candidate pool, leading to economic competition for staff and increased labor costs. patient census report, looking at PCI utilization data for the 4 existing elective PCI centers, regardless of patient origin, demonstrates that for the last 7 fiscal years, the compounded annual growth rate is only 1.6%. Further, the compounded annual growth rate for outpatient PCI, which is the proxy for elective PCI, as defined by the patient census report, is only 0.8% over the last 7 years. According to the SG2 analysis of Norwalk Hospital's primary service area, outpatient PCI utilization is expected to yield 0 growth through 2028. We thank you for the opportunity to testify today, and I am happy to answer any questions you may have.
Ms. Longmore, before I turn you over to my brother counsel for cross-examination, I just wanted to follow up on one point you made in your testimony. You referenced Stanford Health and other area hospitals potentially having to utilize travelers or interim staff in their labs. Just for the sake of the general public, could you put on the record what you mean by utilizing travelers?
Yes. So when we refer to traveler staffing, we refer to licensed and qualified individuals, either technologists or registered nurses, that have a specialty in providing this type of care. And we utilize them on a contracted basis. And those contracted individuals come at a much higher premium cost of care when having to utilize them to fill vacancies. Usually it can be double to triple the amount that you could pay for a normal staff member that's employed by the organization.
Thank you. I have nothing further.
Thank you. This is Benjamin Jensen on behalf of the applicant. Ms. Longmore, thank you for your testimony today. Am I correct? Your background is in both nursing and executive management of hospitals?
That is correct, yes.
Okay, and would you agree that you're not an expert in interventional cardiology?
I've been managing and supervising those areas for many, many years administratively. And I have both a clinical background and an administrative background.
Okay, in the past 15 years, have you been involved in treating patients presenting, requiring an interventional cardiologist?
Involved in the coordination and organization of their care, operationally, administratively, yes. And working directly with those clinicians, yes.
So you're aware that emergency PCIs are already being performed by Norwalk Hospital, correct?
I am aware of that, yes.
And you have no basis to challenge the qualifications of Norwalk Hospital to safely and effectively perform PCI procedures on an elective basis, correct?
Do not.
And rather, your concern is the impact that Norwalk Hospital being able to perform these procedures on an elective basis would have on Stanford Hospital, correct?
That is incorrect.
Okay. Explain why that's incorrect.
Because this is based on what the needs are in the community and the provision of those needs. And there are 4 qualified centers that are fulfilling that need.
And you're concerned about the impact on Stanford Hospital, correct?
Can you be more specific in your question about the impact on Stanford Hospital?
Sure. And I'm looking at your pre-filed testimony. You said that you're concerned that Norwalk Hospital performing elective PCI procedures would inflate labor costs at Stanford Hospital, correct?
So if you're asking me specifically about the question as to whether or not I'm concerned about inflation of labor costs, yes, I am concerned about the inflation of labor costs because of the competition for the same pool of qualified candidates that are already fulfilling those needs at 4 other centers, and still we have a deficit of qualified candidates.
But you don't represent those other facilities, correct? You represent Stanford Health.
I do.
And you're concerned that Norwalk Hospital performing these procedures would inflate your labor costs at Stanford Health, correct?
I'm concerned about the increase in labor costs, yes.
And you're also concerned that Norwalk Hospital performing PCI on an elective basis would divert volume away from Stanford Hospital, correct?
So if there are other centers, yes, there could be other volume that would be absorbed by those.
And you're concerned specifically that volume would be diverted away from Stanford Hospital, correct?
I am here representing Stanford Hospital, yes.
You included a chart at page 7 of your pre-filed testimony, which is Bates number Stanford 0024, titled Historical PCI Utilization by Full Cardiovascular Services Hospitals in Fairfield County. Do you recall that?
Yes,
And this is data that you included that's from the patient census report, correct?
that is correct, yes.
And that means that it's data that is self-reported by facilities, correct?
Yes,
And there's no way to validate the accuracy of these figures, correct?
we're all required to submit these.
But you have no means to validate the accuracy of the other facilities' figures, correct?
No,
And that chart that you included showed, I believe you just testified, a compounded annual growth rate of 1.6% in PCI utilization over the time period from 2019 to 2025. Is that right?
yes,
So it includes the COVID years, correct?
that is correct, yes.
Which is when it included a time when many patients put off elective procedures, correct?
They may have put off procedures for many reasons.
Did Stanford Health didn't have a specific experience with patients putting off elective procedures during the COVID years?
We saw many things that intervened with procedural volumes.
My question was, did Stanford Health have a specific experience of patients putting off elective procedures during the COVID years?
It is possible.
You don't have any specific experience with that?
We see what the volume data demonstrates, but I don't have specific individual reasons.
Looking at the last 3 years of the data you've included, since we've emerged from COVID, and based on this data that you reported, you would agree with me that PCI utilization is on an upward trend, correct?
Which line are you specifically referring to?
Well, let's start in 2022. What was the total number of procedures performed, PCI procedures performed by the 4 facilities you've included?
So it was 1,817,
And how about for 2023?
1,901,
In 2024?
1,985.
And what is the annualized figure for 2025?
It is 2,233.
So over that almost 4-year time period, we're looking at a growth from 1,817 to 2,233 in total PCI procedures at those 4 facilities.
That is correct.
And I calculate that to be about a total of a 23% growth in PCI utilization over that 4-year period. Is that right?
I'm going to assume that that is correct.
Now, you've also included projected figures in your pre-filed testimony at page 8, which is Bates number Stanford 0025, broken down by town, correct?
That is correct, yes.
And while the towns of New Canaan, Westport, and Wilton project a slight decline in PCI utilization, and Weston remains flat, this organization, SG2, projects a year-over-year increase in the city of Norwalk, correct?
Yes, that's correct.
Continuing through 2028.
Yes, that's correct.
Norwalk is where Norwalk Hospital is located.
Yes, Norwalk Hospital is located in.
Norwalk is where the largest portion of Norwalk Hospital's patients reside.
I would assume so, yes.
One of the things that Norwalk Hospital's physicians have testified about earlier is that there's a particular need for expanded cardiac care options in poor, ethnically and racially diverse locations that have been traditionally underserved. Does any of the data that you've relied on in your testimony look at PCI demand in these types of communities?
It does.
Objection, her pre-filed testimony and the information contained in it speaks for itself.
It's a simple question. Does the data that she relied on look at PCI demand in communities that are poor, ethnically and racially diverse and traditionally underserved? Did she include that in her testimony? Is the question.
I'm going to go with that. It's not. I mean, this chart. Okay. I mean, if she has an answer, she can give.
Are you able to answer the question?
We look at all patient sources of data.
And all I'm asking is, did you specifically include any analysis or data looking at PCI demand or utilization in underserved communities, ethnically, racially diverse, poorer communities?
And I'm gonna review my objection because he has access to all of the data that you reviewed. It was included with the pre-file. And this is an argumentative question.
Hearing Officer Novy, it's a very simple question. It's either there or it's not. If I missed it, she can say that it's there. If it's not there, she can say that it's not there. This is not argumentative.
I'm going to allow her to answer. Let's not go too much further down this line.
Agreed.
You had made reference that Norwalk Hospital and the town of Norwalk serves patients that are part of the underserved community. We looked at the projections in Norwalk as a community.
Thank you. One of the other things that you addressed in your pre-file testimony dealt with local traffic and travel time calculations, correct?
That's correct, yes.
Norwalk Hospital's clinicians today have testified, and in their pre-file testimony testified that the majority of myocardial infarctions presenting to hospitals today are non-STEMIs and STEMIs that require urgent intervention, but do not qualify for emergency treatments under the PAMI protocol. You don't dispute that assertion, do you?
I'm not qualified to speak to that specific statement.
NSTEMI patients are having a heart attack, correct?
Yes.
So when you say at page 4 of your testimony, which is base number Stanford 0021, that elective PCI is a scheduled procedure performed on clinically stable patients who are not at significant risk of cardiac arrest or death, and is generally performed on an outpatient basis, you're not basing that on any firsthand experience of treating patients presenting with NSTEMIs, correct?
This statement and what I put in my pre-file testimony related to elective PCI patients.
And I'd like to draw your attention to Exhibit B to your testimony, which is at page 111 of the intervener petition. It is base number Stanford 0110. Do you see that?
I'm on that page. Can you please direct me to the portion that you are looking at?
Sure. So this is from the NCDR CAT PCI registry, correct?
Yes, that's correct.
Okay, and is this the definition you relied on for elective PCI? And it's the first definition there under code 100012987.
I'm just taking a moment to read it.
Sure.
It's an extensive document. Yes, that's correct.
And so when you made reference in your pre-file testimony and your testimony today to elective PCI being for the convenience of the patient and it being a procedure that's scheduled, you were relying on this definition, correct?
That is correct. That is the elective definition.
And what about the definition right below elective, labeled urgent?
I see the reference there, yes.
The definition there says the procedure should be performed on an inpatient basis and prior to discharge because of significant concern that there is a risk of ischemia, infarction, and or death. Patients who are outpatients or in the emergency department at the time that the cardiac catheterization is requested would warrant an admission based on their clinical presentation. Did I read that correctly?
It's what is stated there in the register, yes.
To your knowledge, if a patient presents at Norwalk Hospital with an NSTEMI, with an urgent condition, is Norwalk Hospital able to do that procedure?
Not this,
So elective PCI, as the state has interpreted, it includes both the definition of elective as well as urgent. Do you agree with that?
it's elective.
I'm sorry?
Elective as well as urgent, you said?
Correct.
So it is elective as well as.
So when you say in your pre-file testimony that local traffic and travel time discussions in the application are not clinically relevant to this population, you're not talking about patients that would fall into this urgent category, correct?
This is urgent, it is not emergent.
An emergent would involve an emergency surgery, a primary PCI, correct?
The reference here, though, does not state where in which the patient has to have the procedure performed.
And it's
It is
Stanford,
not
I'm sorry.
emergent, and it is not emergent. It is urgent, and there is a difference between.
But your testimony was relying on the definition of elective, correct?
Yes, and you've asked me to clarify my testimony, and I just did in relationship to speaking about both elective and urgent.
And at Stanford Hospital, when patients present with urgent conditions, you don't have to transfer them. You don't have to transfer patients that are having a heart attack to drive 9 miles on I-95 to get urgent care, correct?
We do not, because we are one of the 4 centers that are able to do this.
You would agree with me that in assessing public need for services, OHS should take into account how patients access care, yes?
Objection, the statute speaks for itself.
It's not an objection.
Um,
She has opined on how the statutory criteria should be applied in this context, and I'm asking her about what, she has offered an opinion on what OHS should consider, and I'm asking her about how she defines public need. Thank you.
Would you please restate your question?
Sure. You would agree with me that in assessing public need for services, OHS should take into account how patients access care.
Yes, I would.
You would also agree with me that OHS should take into account the individual demographic needs of the community. Yes?
If it is under their purview, then yes.
And OHS should take into account the patient population's ability to access care in their communities and how far they would have to travel if a particular type of care is not available in their community. Yes?
Yes, and I provided that in my pre-filed testimony.
And that's also something that you said during public comments, the OHS statewide facilities plan acute care bed need work group, correct?
Yes,
And you stand by those statements?
yes, I do.
Thank you. No further questions.
Thank you, Ms. Longmore. Stanford Health now calls Dr. Scott Mark.
Good morning, hearing officer Novak and OHS hearing panel. My name is Scott Martin, and I adopt my pre-filed testimony. I'm the Director of Interventional Cardiology and Cardiac Cath Lab at Stanford Hospital and Stanford Health Medical Group. My testimony this morning is pretty limited in scope, so I'll try to be brief. What I'm here to say is that the PCI business is not really a growing business. We have 4 centers locally already performing these procedures. And, you know, the evidence is that there is not a growing need. Both internationally, nationally, and locally, the trend for PCI is flat. You know, we can find, 1% growth at different times, and we've rebounded to near pre-COVID levels, but it's really not a growing business. And we should celebrate that. Heart disease is a huge burden on our health economy. heart disease is still the #1 killer of people. You know, it kills more than all cancers combined. And as the population's aging, we have increase in a lot of different heart diseases, heart failure, atrial fibrillation, hypertensive heart disease. But one of our successes has been in ischemic heart disease or atherosclerotic heart disease or coronary artery disease. These conditions that PCI treats. You know, we've included an exhibit showing that a pretty dramatic reduction in ischemic heart disease burden nationwide and worldwide. You know, the rate of death from heart attack is down dramatically in my lifetime. And you know, the main reason for that is that we have better medicines to treat heart disease, to treat ischemic heart disease. Cholesterol medications have made a dramatic difference. You know, we've got potent statin drugs over the last 30 years and now more options in cholesterol medications. And our medical treatment is only getting better. PCI is a life-saving and dramatic treatment for acute MIs. And I'm glad that Norwalk Hospital has that capability. I live in Weston, so if I have a heart attack, I will be brought at home. I'll be brought to these fine gentlemen to take care of me. And I'm glad they're there. But for a elective PCI, the continued improvement in medical therapy has flattened the trend and, you know, has made the procedure less necessary. You know, since 2007, there have been a number of trials showing that for stable ischemic heart disease, medications do as well in general as treatment with PCI. We cited the ischemia trial from 2020 that showed for routine use, you know, for stable ischemic heart disease, patients did just as well with medical therapy as they did the addition of PCI. And the medical therapy is only getting better. You know, we cited, you know, the use of the newer medications like Ozempic and Zepbound, Farxiga and Jardiance that are further decreasing you know, the ischemic heart disease burden. We also cited there's other evidence when people do have more severe disease that bypass surgery is still a better option than PCI for a lot of these patients. So we're getting kind of squeezed from both ends. You know, I would be thrilled if the need for PCI was growing. You know, I wear a suit about once a year. You know, all other days I'm in scrubs in the cath lab doing these procedures. And, you know, if we were doing more, it would be good for me. It'd be good for Stanford Health probably. But, you know, that's just not the case.
Thank you, Dr. Martin. Again, Ben Jensen on behalf of the applicant. I'd like to start with what I think we agree on from your testimony. You agree that Norwalk Hospital is already performing emergency PCIs for patients?
Yes.
In your pre-filed testimony, your comments today don't raise any safety concerns about Norwalk Hospital performing emergency PCI procedures, correct?
Correct.
And likewise, your pre-filed testimony does not identify any safety concerns about the qualifications of Norwalk Hospital and the physicians and staff in its cath lab to safely perform elective PCI procedures with state approval, correct?
Correct. I have no specific concerns.
So instead, your testimony is limited to the issue of whether there is a need for another provider authorized to perform non-emergency PCI procedures in Fairfield County, correct?
Correct.
And in assessing whether public need exists, you looked at trends in ischemic heart disease at the national level, correct?
At the national level, the worldwide level, the local level. I mean, you know, it's the trends are due to treatments that are available both nationwide and locally.
Well, and I'm specifically looking at your pre-filed testimony that you submitted and that data that you reported indicated a decline in ischemic heart disease in the United States as a whole, correct?
Correct.
And in your pre-file testimony, you also looked at elective PCI utilization trend data, correct?
Correct.
And that was data during the time period from 2010 to 2017, which showed a decline in elective PCI rates during those years, correct?
I believe that's correct.
And in interpreting that data, you stated in your pre-file testimony, the elective PCI decline occurred predominantly between 2010 and 2013 and remained flat in the following years, which would be up to 2017, correct?
Correct.
Now, in your pre-file testimony, you don't provide any regional or statewide data to support your conclusion that there's been a decline in PCI procedures, correct?
No, that's not included in my testimony.
And you also don't provide any data at the local level in the Stanford or Norwalk service areas, correct?
Again, not in my testimony, correct.
And your pre-file testimony does not address any issues with access to cardiovascular care in underserved communities with higher poverty rates and higher levels of minority or foreign-born individuals, correct?
I would not consider myself an expert on any of those matters, and so no, not in my testimony.
Now, your testimony, your pre-file testimony does reference the data that Elizabeth Longmore cited to in her pre-file testimony, correct?
Correct.
And as we just discussed with Ms. Longmore, the data that she relied on showed that PCI procedures at the local level have increased over the last 3 years, correct?
Correct, yeah, there was a pretty dramatic decrease. She didn't comment on the COVID year, but I was in the cath lab and I will attest that we did shut down elective procedures for a while. And our drop off was significant that year. And, we have come back in the subsequent years to, like I mentioned, near COVID, pre-COVID levels.
And have you had an opportunity to review any of the CHIME data that Norwalk Hospital provided in its written response to the OHS issues list, which is at base numbers NH 0469 to 0470, that show a year-over-year increase over the past 3 years in both cardiac catheterization and PCI procedures?
I reviewed the testimony that was filed, so I'm sure, yes.
You don't have any reason to dispute the CHIME data showing that there's been a year-over-year increase in the past 3 years in cardiac catheterization and PCI procedures?
I have no reason to dispute that.
But regardless, based on the data that you did consider at the national level from the 2010 to 2017 time period, you concluded in your pre-file testimony that the only way Norwalk Hospital can achieve its volume projections is to divert patients from the existing PCI programs located in towns contiguous to its service area. Correct? That was your conclusion?
Correct.
And that's concerning to you and to Stanford Health because Stanford Hospital is one of those existing PCI programs located in a contiguous town, correct?
Correct.
Now at base numbers Stanford 017879 to 180, you discuss novel glucose lowering drugs, medications like GLP-1 drugs and SGLT2 inhibitors, is that right?
Yeah, I don't have the page in front of me, but yes.
Okay, and your reason for including that was based on your contention that those medications can reduce major cardiovascular events, correct?
I think that's been pretty well established in randomized controlled trials. So it's not a contention, but yes.
Based on the evidence, that's what you brought forward, correct?
Correct.
Now, your comments in the pre-file testimony don't discuss the availability of these medications in underserved minority communities, did they?
Not discussed, correct.
Do you have any experience with the availability of medications like these in underserved minority communities?
I do, so I'm largely work in the cath lab, but I do see patients in the office. It's gotten dramatically better. So for obesity, it's still quite hard to get, these medications. But if they're diabetic or have sleep apnea or fatty liver, by and large, if you have commercial insurance or Connecticut, they're usually obtainable. If you have no insurance, then they're out of reach.
And as a general matter, building off that, are those medications reimbursed by government payers for any conditions other than type 2 diabetes?
Government payers being,
Medicare, Medicaid?
I don't believe so.
And regardless of pharmaceutical advancements and the advent of healthy living initiatives, you would agree that heart disease continues to be the leading cause of death in Americans?
Yeah, I testified to that, and, you know, I think it's a mixed bag where, you know, the aging population certainly, you know, is not gonna, heart disease is not gonna go away. And yes,
And that's also true in Connecticut, it's the leading cause of death.
that I don't have expertise on, but I believe, I have no reason to doubt that.
And you would agree that PCI remains a standard treatment for patients experiencing STEMI, NSTEMI, and unstable angina?
Yes.
Now, this isn't the first time you testified at a public hearing in connection with an application by a community hospital to offer elective PCI services, correct?
That is correct.
Stanford Hospital previously intervened to oppose Greenwich Hospital's application to perform those procedures, correct?
Yes,
And you testified at that hearing in opposition to that application?
I did.
And Norwalk Hospital previously applied to perform these procedures, and Stanford opposed that application, correct?
Correct.
And you testified at that hearing?
Yes.
During your testimony in the prior Norwalk Hospital CON application, which was docket number 20-32390 CON, you agreed that allowing a patient to remain with a provider of choice is something that could be viewed as a public benefit. Your view on that hasn't changed, I take it?
I don't remember saying that, but that sounds reasonable to me.
You were also asked during that hearing if not requiring a patient to travel to get needed care when the circumstances don't require it can be a public benefit. And you said all other things being equal, patients are better off having a choice and being able to do things closer to home. You haven't changed your opinion on that, correct?
Correct.
During your testimony in the Greenwich Hospital CON application, which is docket number 20-32342-CON, you said, and I quote, "I agree that patients should have the choice to stay local, if at all possible, if it can be done safely." Do you recall that?
I don't recall it, but I say a lot of things, so I believe you.
You haven't changed your opinion on that issue, correct?
Correct.
No further questions.
At this point,
I just have one question on the direct. Dr. Martin, do you recall when Attorney Jensen was asking you questions about elective PCI and trends
Yes.
and about the numbers pre-COVID and post-COVID?
I brought up COVID, I think, but yeah, yes.
Fair enough. And I believe you testified, and you can correct me if I'm wrong, that the numbers we're talking about now, although rising from the COVID years, are just now reaching or equalizing the number of PCIs that were elective PCIs that were done pre-COVID.
Like,
So
no,
you were heard.
I think that's correct. You know, I know at Stanford Hospital, that's correct. You know, I think we're still below the pre-COVID numbers. And then, you know, if I look at the chart from the 4 local hospitals, it looks like, you know, finally in 2025, we're estimated to exceed 2019.
Thank you. I have nothing further.
okay, fine. Sorry about that. At this point, it's 12:05, and I would like to begin, the public comments close to 1 p.m. as possible. So what I would like to do is break now to lunch so that we can start our public comments close to the annual times we can. If we could all meet back here at 1:05, I know we're going to postpone public comment for 5 minutes, but we could all be promptly back. I would appreciate that. And then afterwards, we will do OHS questions after public comment. So they have your applicants to the extent possible, and we've already talked about and having. We'll see you all at 1:05. Thank you. I gave the beginning. Figure it out.